my name's Bryan Williams. I'm from University College in London, and I'm here at the ESC where we've just completed an excellent session on challenges in hypertension. And it's interesting that today one of the challenges that prevails is how do we make the diagnosis of hypertension. I have two world experts in this field with me here today. The first is Kazuomi Kario from Tochigi in Japan, and Paolo Verdecchia from Perugia in Italy. Paolo, maybe if I could turn to you first. I mean, you gave one of the first presentations and you were talking about the difficulty in making a diagnosis of hypertension. Do you think that the majority of people now should have a diagnosis confirmed by ambulatory blood pressure monitoring?
Yeah, I do believe that most patients with hypertension should receive ambulatory blood pressure monitoring as suggested by many hypertension guidelines today for several reasons. First, because ambulatory blood pressure allow to identify, for example, patients with white coat hypertension, also referred to as isolated office hypertension. That is a condition in which office blood pressure is abnormally increased, while in the same time out of the office blood pressure, that means 24-hour ambulatory blood pressure, is perfectly normal. And these subjects seem to be at lower cardiovascular risk than those with both increased office and out of the office blood pressure.
And it's quite interesting because we looked at this when I was doing a guideline with NICE here in the UK, and we found that in our analysis about 25%, 1 in 4 people potentially diagnosed with hypertension actually had white coat hypertension.
Yeah, the prevalence, depending on several factors, can vary from study to study, as always happens. But on average, about 20-25% of hypertensive patients might have white coat hypertension. But there is also another very insidious and risky condition that is masked hypertension.
Well, maybe I can come to that in a minute, because I was just going to ask Kazu, we talk about ABPM, but not everybody in the world can get access to ABPM. Other countries, maybe home blood pressure monitoring is more widely available. Do you find that as good as ABPM? Is it something that we can use instead of ABPM?
I completely agree. The ABPM is the standard, gold standard. But clinically, practically, the home blood pressure monitoring may be alternatively used. Recently, we can measure the sleep pressure using the home pressure monitoring. But the daytime pressure, especially stress-induced daytime hypertension, could be may underestimated using the
So what you're saying is that basically, most of the people doing home readings do them when they're seated at home, so you're missing out on all of the changes in blood pressure when people are ambulant and at different times during the day and night, which is a really big challenge. Paolo, you were going to go on about masked hypertension, which many people may not even have heard of as a real problem. So maybe how would you define masked hypertension?
Yes, the masked hypertension in a certain sense reflects our uncertainty, reflects our false impression that the blood pressure of our patient is normal because their blood pressure in the office is below 140/90 millimeters of mercury. So we believe that their blood pressure is normal.
We shouldn't be worried about them. They're all got normal blood pressure. I
mean, they are normal blood pressure if untreated, or well-controlled blood pressure if they are treated. But in the same time, many of these patients tend to have high blood pressure out of the hospital setting. That's called masked hypertension. And this condition is insidious because these patients, despite their apparently normal blood pressure in the office, tend to have an increased risk of target organ damage and more cardiovascular events.
You kind of expect that if they're walking around with a high blood pressure when they're not in the doctor's office, which is most of the time, not being treated, not being detected, they're almost going to be at higher risk, aren't they, than anybody else?
They have a high risk. The risk of cardiovascular events is 2 to 3-fold higher in those with masked hypertension than in those with perfectly normal blood pressure, both in the hospital and out of the hospital.
So the big question, and we debated this at the meeting today, is how on earth do we identify these people? Because you know, they're coming up for health screening. They're going to their workplace. They're going to their doctor. The doctor measures their blood pressure, says it's fine. Less than 140/90, your blood pressure is normal. How do we pick them up?
Fortunately, some predisposing conditions or predictors of muscular hypertension has been identified. So when we have in front of us a patient, a subject or patients with a normal clinic blood pressure, we should suspect muscular hypertension if he has a high normal blood pressure, because we know that a high normal blood pressure predicts muscular hypertension. Or
so if you have a high normal blood pressure in clinic, you'd recommend that you'd also do out-of-office monitoring
correct.
on them. Okay,
that's correct.
Interesting.
Another condition is cigarette smoking.
Okay.
Because you know that usually a patient does not smoke during clinical visit, but may smoke out of the hospital. We hope. But out of the office, he can smoke or she can smoke, and smoking can significantly elevate blood pressure during the 24 hours. So predisposing to the muscular hypertension. Another condition is high level of stress. Working stress, high-strain job stress, or family stress for family reason, high levels of physical exercise, also other conditions including, for example, diabetes, metabolic syndrome, sleep apnea, snoring or sleep apnea are all conditions that can increase the likelihood of having...
So, I mean, I think it was a really interesting session, and I'd just like to thank both of you for making a few comments about the session today. What we learned today in the session is that there is now much more enthusiasm for using out-of-office blood pressure measurement, either with ambulatory monitoring or home monitoring, to better characterize whether somebody really has hypertension before they get treated, and also to define whether their blood pressure is optimally controlled when they are treated, because sometimes the clinic information isn't as accurate as we would like it to be. Thank you.